Welcome again, everyone. So we're going to have a great presentation today. Of course, we'll start with where are we now and surveillance and clinical updates, as we usually do. The clinical updates this week will feature an update on MIS-C, otherwise known as the Kawasaki-like syndrome or multisystem inflammatory syndrome temporally associated with COVID. And so we'll just have a brief update on that. And for our spotlight, we're actually going to build on the excellent presentation Dr. Foote did a couple weeks ago about forward planning and the as we start to reopen, what we're going to start seeing and what we're going to start thinking about. And then we will, time permitting, have some questions and discussion. You can put your questions into the Q&A box. And we will try to answer them during the talk if you have them as the talk comes. And it's from that Q&A that we'll have our questions at the end. I also want to remind everyone that usually around Monday afternoon or Monday evening, all of these slides and a recording of this talk will be posted on our provider website, and we can add a link to that in the chat box or the Q&A box. So for the worldwide update and where we are now, there are over 5.5 million cases and 350,000 deaths due to COVID confirmed worldwide. And so in some areas, we are seeing places that were closed down or that had implemented physical distancing measures open up, but we are seeing outbreaks accelerate in other parts of the world. We're pointing out South America as an area that's close to us that has seen a rapid increase in cases. In New York City, on the other hand, we have had a sustained decline in our case counts, our hospitalizations, and our deaths. But I think the lesson to learn from what's going on in the world is that although we are transitioning into a new stage in the pandemic response, which is suppression, where we will start to see things open up, we do have to maintain prevention measures. And so this is a map from the World Health Organization of cases worldwide. Each of the circles represents the number of cases, with a larger circle representing a larger number of confirmed cases. And as I said, there are over 5.5 million cases with over 350,000 deaths. And then I'll just point out these relatively large circles in South America, which if you compare them to the same maps that we had shown previously, were smaller. In the United States, as you can see, although we keep saying that New York City's cases are leveling off, and you'll see more of that in the data as we proceed, the largest number of cases is still in New York and the surrounding area. That's the largest number of cumulative cases and deaths, and so that's the largest number of cumulative cases, meaning that from the very beginning of the response to the very end of the response. Overall, in the United States, we have over 1.7 million cases and over 100,000 deaths. So both of these represent about a third of the cases and the deaths that we have seen in the entire world. And this is just a closer look at cases and deaths in the United States on a day-by-day basis. And if you look at these curves, in both the cases and the death curves, you see that there was a high somewhere in April. And at this point, we've leveled off in the number of cases with a slight decrease. And it looks like a big decrease in the deaths. However, we do have to remember that the deaths always lag behind the cases. I think that the important point to take here is the one that we have been making throughout, that these cases overall in the United States are an average of areas where average of places like New York City where physical distancing measures were implemented, and we have seen a decrease in the number of cases and concomitantly the number of deaths. But also there are areas in the United States where the cases are increasing, and these two, you can't tell the difference between those in these graphs that look at the entire United States. So what are we to do? And I think one of the answers is to understand the local risk of the disease and the local situation. And we have a link here to New York City Health Department's excellent data page. There's a lot of detailed data broken down in a lot of different ways on this site. You can always go to the site to look at the up-to-date data on what's going on in New York City related to COVID. And so we have almost 200,000 laboratory confirmed cases since the beginning of the outbreak, over 50,000 hospitalizations, and we have almost 17,000 deaths and almost that are confirmed, meaning that they were associated with a positive COVID test, and almost 5,000 probable deaths, meaning that based on the death certificate info or other clinical information, this is likely from COVID, but we don't have a positive test to confirm that. And in this curve, you can, or in these curves, you can see cases, hospitalizations, and deaths in New York City. And I think that the main point to take from all three of these is that there was a peak in the cases around April, and that now they have significantly declined. I spoke about some of the data that are broken down, and some of these data require, it's a little difficult to interpret them, and there are many possible explanations. So over here we have two maps. We have the case rate per 100,000 of population in different zip codes in New York City, and we have the death rate per 100,000. And this is the confirmed death rate, meaning a positive COVID test. And you can see that these two maps look similar, but not entirely the same. And as we'll show you in some of the upcoming slides, there are a couple issues going on here. So one is access to testing. So if you test more people, if you test a higher percentage of the population, you're going to uncover more positive tests, meaning that if you don't test a positive person, they won't show up as a positive case. We know that there are other factors, for example, by age and race, that impact the death rate of people who do get COVID disease. And so the health department is working on parsing out exactly what the causes are between the differences in these two maps. But I encourage you to go to our website and take a look at these yourself, especially to understand the details of what is going on in your own neighborhood or the neighborhood of where many of your patients come from. And so this is some of what I was talking about with regard to what is associated with death amongst people who contract COVID-19. And in the first graph, we can see that age certainly appears to have an impact, with persons over 75 having a significantly higher death rate. For race and ethnicity, we see that Black or African American and Hispanic or Latino persons have nearly double the death rate of Asian Pacific Islander and white persons who contract COVID-19. Similarly, poverty appears to have a relationship with death and COVID-19, where very high and high poverty areas, as the prevalence of poverty increases, the death rate increases in different neighborhoods. And for the last interesting data we want to show you related to the epidemiology of COVID-19, where these two graphs that I'm showing look at testing and what we're finding out from testing. So the first graph, actually both of these graphs, look at the day-by-day number of tests. The first graph looks at the day-by-day number of tests. So this is not the cumulative number, the total number of tests done in New York City. It's actually the number of tests done on that day. And you can see certain days of the week, I believe they're weekends, fewer tests are done because fewer people go to the doctor. You can see overall there's a trend where since the beginning, since the beginning of pause and actually even before, testing has increased significantly. However, at the same time, you'll notice after this peak, and certainly after physical distancing was implemented, we actually are starting to see a decrease in the percentage or the number of people, the total count of people who test positive. So even though more people are being tested, we are seeing fewer new positive COVID cases. And the second graph shows the data in a different way, where it shows the percent of people with positive results by date. And of course, this means that if the number stayed the same, but we were doing more tests and testing more negative people, the number might go down. But we see from the first graph that there are actually fewer total people who are testing positive. And I think that's it for the epi. And then I just want to double check if Dr. Schillinger, did you get your microphone to work yet?
Yes, I think I did.
All right, great. Would you like to present this
Yes.
C slides?
Yes, thank you. Thanks for having me. Next slide, please. So what we are now calling MIS-C, multisystem inflammatory syndrome in children, is a serious illness that we are seeing temporally associated with the coronavirus pandemic. And it has some clinical features of Kawasaki disease, as well as some features of toxic shock syndrome. Typically, a child presents with fever that has been lasting for several days, often high fever, but not always, along with some other symptoms. And these can include gastrointestinal symptoms such as abdominal pain, diarrhea, and vomiting. In fact, some of the children have abdominal pain so severe that they have been taken to laparotomy for appendicitis. They often have conjunctivitis, rash, irritability or sluggishness, and lymphadenopathy. The important thing about this syndrome is that we still don't know the full breadth of the symptoms that are associated, and the spectrum of illness itself is still being defined. What we know best is what is being seen in hospitalized children. And they also have elevated inflammatory markers, including those that reflect myocardial damage. The majority of these patients, those who have had antibody testing for SARS-CoV-2, the majority are positive for antibody. A smaller proportion are positive for the virus by PCR. But the current thinking among many is that this syndrome reflects an illness that is mediated by the immune response rather than by direct viral injury. Next slide, please. So by local and state law, New York City is now requiring reporting of any suspected cases of MIS-C. And our reporting requirements are aligned with those of New York State. Required is reporting of any individual under the age of 21 who meets clinical and general laboratory criteria, which I will outline, and who does not have an alternate diagnosis. The clinical criteria require all three of: first, at least 1 day of subjective or measured fever; second, hospitalization; and third, either one of hypotension or shock, features of severe cardiac illness, or other severe end organ involvement, with the exception of respiratory disease alone; or two of the following: macular papular rash, bilateral non-purulent conjunctivitis, mucocutaneous inflammatory signs, or acute GI symptoms. The general laboratory criteria are at least 2 markers of inflammation, and there are a few examples there, but as I mentioned, many of these children have elevated fibrinogen and BNPs and other indicators of inflammation. When you look at the New York State reporting requirements, you will see that there are other criteria, but in fact, because New York City is considered an area where there is ongoing coronavirus transmission, these are the only criteria that one must meet to be reported. So you do not need to have, for example, any laboratory confirmation of coronavirus infection. Next slide, please. So we are asking providers to report to us by calling the City Health Department at the Provider Access Line, which is 866-692-3641. As I mentioned, children should be reported regardless of laboratory evidence of SARS-CoV-2 infection. And we ask that Miss C be considered in any pediatric death that does have evidence of SARS-CoV-2 infection. When we get reports, we are investigating all of them and reviewing whether or not they meet the CDC case definition. And the link to the case definition is at the bottom of this slide. As of May 28th, we have received 203 reports of suspect cases, and we have found that 124 of them meet the CDC case definition for Miss C. 39 did not meet the CDC case definition, and 40 are still under investigation. To date, there has been 1 death reported. And I think that's it for me. Thanks.
Hi, I'm Dr. Betty Kolod, and I'm an internist and preventive medicine resident rotating in acute care planning and strategies at the health department. I'll be speaking about the transition from inpatient to post-hospital care of individuals with COVID-19. I will start by discussing 3 of the most devastating complications of severe COVID-19 illness: multifactorial functional impairment, ongoing need for mechanical ventilation, and kidney injury. Next, I will explore some of the barriers to discharge and management in the most appropriate post-hospital setting. Finally, I will describe a selection of the needs and complications of moderate COVID-19 illness and the features shared by many COVID-19 post-discharge clinics. Traditionally, the focus of intensive care is the short-term survival of the patient, but it is well established that intensive care survivors suffer a variety of consequences after discharge from the ICU, including increased mortality and global functional decline that affects the quality of life of both the patient and caregivers. Recovery can take years, if at all possible, and complications can include cognitive impairment to the degree of mild Alzheimer's dementia for nearly a quarter of survivors 1 year after discharge. Anxiety, depression, and PTSD are common and comorbid in nearly 20% of survivors. And in addition to the muscle atrophy of critical illness and prolonged hospitalization, survivors of acute respiratory distress syndrome can develop flexion contractures from long periods of immobilization. This grim prognosis is termed post-intensive care syndrome, though hospitalized patients on general medical wards are at risk as well. Here, you can see the wide variety of domains of impairment, grouped into cognitive, psychological, and physical complications. The impact is devastating, and 1/3 of survivors with post-intensive care syndrome will never return to work. Another third will not return to their occupation or salary. The effect on the earning potential of communities that are disproportionately affected by COVID-19 remains to be seen, as many members of these communities are precariously employed prior to COVID-19. Post-intensive care syndrome can have a significant impact on caregivers. 25% of individuals with post-intensive care syndrome experience a loss of independence requiring assistance with activities of daily living 1 year post-discharge. The cognitive and emotional symptoms of post-intensive care syndrome are also recognized in caregivers. Survivors of severe COVID-19 are at particularly high risk for post-intensive care syndrome. On the right of this table, we see the risk factors for post-intensive care syndrome, and on the left, we see how the experience of individuals with severe COVID-19 illness perfectly mirrors these risk factors. This highlights the necessity of prompt, intensive rehabilitation and mental health services for survivors of severe COVID-19 illness, in addition to preventive measures implemented in the ICU. Is our health system equipped to provide these services to survivors? Let's shift to pulmonary morbidity associated with severe COVID-19 illness. In a prospective cohort of 1,150 patients hospitalized in New York City for COVID-19, 18% required mechanical ventilation. But shockingly, the median number of days requiring the ventilatory support was 18, higher than other geographic locations. Anecdote from other New York City hospitals further reflects the difficulty of weaning these individuals off of the ventilator, with about 9% of 197 patients surviving mechanical ventilation undergoing tracheostomy. Many centers are performing tracheostomy early, prior to ventilator day 14. But few patients are decannulated by discharge, and those who are not must be placed in facilities with capacity for mechanical ventilation. Kidney injury is the third complication of severe COVID-19 illness that I would like to describe. In a cross-sectional study of 5,449 patients admitted with COVID-19 to 13 academic and community hospitals in New York City, 36.6% developed acute kidney injury, and 14.3% went on to require renal replacement therapy. However, among those requiring mechanical ventilation, 89.7% developed acute kidney injury. Of patients requiring renal replacement therapy, 96.8% were on a ventilator as well, though half of those with the most severe kidney injury expired. Anecdotally, due to staffing shortages during the peak of the surge, many patients were started on peritoneal dialysis, for which post-discharge capacity is unclear. Further, likelihood of renal recovery is unknown at this time. Thus, those surviving both mechanical ventilation and renal replacement therapy may require placement in a ventilator facility with dialysis capacity. But before discharge, there are a number of obstacles patients must overcome. In addition to tracheostomy and feeding tube placement, which may be delayed due to bleeding risk and other factors, patients may have ongoing complex medical needs that complicate their placement in an appropriate post-hospital facility, which I will discuss further on the next slide. Additionally, according to the executive order of the governor, all patients must have a negative SARS-CoV-2 PCR prior to discharge to a nursing facility, though we have seen sustained positivity for longer than 1 month among patients in intensive care. These obstacles lead to further prolonged hospitalization and further functional decline. Once a survivor of severe COVID-19 is ready for discharge, the question is what type of rehabilitation, also known as post-acute care facilities, are available and appropriate. Long-term acute care facilities are the best option for many of these individuals because they provide hospital-level care, including IV medications, nasogastric feeding, and hospital-level clinical staffing with intensive physical rehabilitation, vent weaning, and renal replacement therapy. The challenge, however, is that the New York State Department of Health must issue a certificate of need before a long-term acute care facility can be established. And New York City only has one long-term acute care hospital. Alternatively, skilled nursing facilities are more readily available. However, they are not generally equipped to care for individuals who require intensive physical therapy or mental health services, the care of a physician, or weaning from a ventilator. Troublingly, few skilled nursing facility beds are available for individuals who require both mechanical ventilation and renal replacement therapy. Further, New York State skilled nursing facility beds have a higher than national average occupancy rate. Here we see that the overall number of skilled nursing facility beds is equal to or less than the daily number of persons hospitalized for COVID-19 in both the boroughs with the lowest and highest bed availability. Understaffing was a challenge prior to the pandemic, and now illness and fear of contracting COVID-19 are exacerbating this concern. But policy solutions have been proposed. To address infection control concerns leading to pre-discharge testing requirements, facilities could adopt a center of excellence model, allocating resources to particular nursing facilities to care exclusively for those with COVID-19. To increase overall bed capacity, rural or low occupancy hospitals or even hotels or dormitories could be converted into nursing facility beds. To meet staffing needs, workers could be recruited from industries with high numbers of layoffs, so they would need training and paid sick leave. Finally, investments could be made in hospital at home programs, which can provide daily medical visits, lab testing at home, and regular nursing. Now let's discuss a selection of the considerations in caring for less debilitated COVID-19 survivors, leading into a model for post-discharge COVID-19 clinics. First, I will define requirements for home isolation and discontinuation of transmission-based precautions. Next, I will share guidelines for post-discharge management of anticoagulation. Third, I will describe the morbidity of mental illness among those with less severe COVID-19. And finally, I will mention differences between the availability of physical therapy and cardiopulmonary rehabilitation and give an example of simple assessments. First, on discharge, or ideally prior to discharge, an assessment must be made of a patient's ability to isolate at home. Home isolation requires support, space, resources, including food and infection control supplies, and other members of the household should not be excessively vulnerable to COVID-19. If this is not possible, the patient or vulnerable household member can be referred to an isolation hotel through the Health and Hospitals COVID-19 hotline. Once the individual is discharged, a symptom-based strategy for discontinuing isolation will be most feasible. This requires 10 days from symptom onset, resolution of fever for 3 days without antipyretics, and overall improvement in symptoms. Test-based strategies, the test-based strategy is more sensitive, but it may be less accessible as it requires 2 negative PCR tests greater than 24 hours apart. Another consideration your patient is likely to face is anticoagulation. A prospective cohort of 198 hospitalized patients in Amsterdam objectively confirmed venous thromboembolism in 5.8% of patients with COVID-19 on general wards by hospital day 7, and 59% of 75 ICU patients by day 21. As a result, many of our patients are discharged from the hospital on heparin products or direct-acting anticoagulants. Understanding and counseling patients on their anticoagulation can be a challenge, but Bicdelli et al. Published guidelines shown here that are endorsed by multiple US, European, and international societies. As you can see, it stratifies patients into 3 groups. Those hospitalized for COVID-19 with risk factors for venous thromboembolism, including reduced mobility, active malignancy, or D-dimer 2 times the upper limit of normal, who are recommended to complete less than or equal to 45 days of prophylactic anticoagulation. A second gray area of those who were found to have a significantly elevated D-dimer, but no objective evidence of venous thromboembolism, are thought to benefit from anticoagulation of microvascular thrombi based on limited data from China. The authors varied in their recommendation of prophylactic, intermediate, or full dose anticoagulation for this group. This is the group in which individual clinical judgment is needed. Finally, in patients who had objective evidence of venous thromboembolism, the panel recommends therapeutic anticoagulation for a minimum of 3 months. Psychiatric morbidity is ubiquitous among individuals with mild to moderate presentations of COVID-19, and even among the general public. The SARS outbreak of 2003 was considered a mental health catastrophe, and at least a third of patients developed anxiety, depression, PTSD, and substance use disorders. Early COVID-19 data from China show that individuals with stable disease under self-isolation had median anxiety level of mild to moderate. Post-traumatic stress disorder was noted in 96.2% of survivors who were stable but held in isolation hotels. Mental health services will not be adequate to accommodate an influx of this volume, and the burden will fall on primary care and COVID-19 follow-up clinics to provide a minimum of anxiety reduction and stress management techniques. Physical rehabilitation is also a focus of the post-discharge care of patients with moderate COVID-19. Ideally, patients requiring intensive rehab will be discharged to appropriate post-acute care facilities. Additionally, those who need less intensive physical therapy can participate in rehab over telemedicine. However, remote cardiopulmonary rehabilitation is not reimbursable at this time. Pulmonary rehabilitation can be effective in the treatment of dyspnea and the promotion of independence and quality of life, even if a patient is not able to access formal rehabilitation. With the aid of a pulse oximeter or even without equipment, however, it is possible to assess and diagnose pulmonary dysfunction and target the specific type of dysfunction. A few simple assessments are shown on this table, which can help tease apart dyspnea. For example, in the 1-minute step test, you can have your patient step up and down onto and off of a single step for 1 minute. And if you find the changes in vital signs shown on this table, then you can diagnose severely impaired endurance. The Borg dyspnea scale can be used as well, which is a subjective measure of dyspnea. And if you do diagnose severely impaired endurance, then you can simply prescribe free walking to the patient to improve their endurance. Since the recognition of post-intensive care syndrome, post-ICU or post-discharge clinics have been discussed as a model to support patients with the complex needs discussed. Many such clinics have been established for the care of survivors of COVID-19, with one approach comprising nearly daily contact for a limited period of time, such as 1 week. Key features include care coordination to facilitate comprehensive assessment of patient needs on discharge from the hospital, participation of relevant specialties in primary care, and importantly, assurance of regular and reliable communication with patients and overwhelmed caregivers, which can calm anxiety and prevent emergency department visits. This degree of coordination requires participation at multiple titles, including nursing and medical assistance. Anticipatory guidance regarding COVID-19 complications where possible, and attention to comorbidities that can be exacerbated by illness, social upheaval of the pandemic, depression, and COVID-19. Telemedicine, in particular video visits, is a necessity for now, as clinics are open at a limited capacity. But going forward, this technology will remain essential for COVID-19 survivors who are overwhelmed, functionally impaired, and have many appointments, leading to increases in no-show rates for face-to-face appointments. Where possible, distribution of durable medical equipment, including pulse oximeters, blood pressure cuffs, and thermometers, can significantly augment evaluation by telemedicine. For example, allowing assessment of orthostatic vitals. And a final feature of many of these clinics is outcomes research to learn about the impact of COVID-19 in our communities and help plan for future phases of the pandemic. Some crowdsourced best practices are listed here, including group visits over video conference to help patients normalize and cope with their traumatic experiences and to manage the volume of visits with COVID-19 survivors. Additionally, as listed, we described reliable, regular contact, so patients and caregivers know that they can reach the clinic rather than going to the emergency department if they have a change in status. We mentioned simple functional assessments from the 1-minute step test to a simple walk test with pulse oximeter, stress management, whether or not the patient is able to access psychiatric care, and if possible, same day or next day appointments with specialists. In conclusion, I presented multiple clinical complications of severe and moderate COVID-19, but I hope to impress upon you the magnitude of weakness, cognitive decline, and psychiatric morbidity survivors face, and to empower us to prevent, diagnose, and treat the many contributing factors. I also hope we can remember and advocate for increases in long-term acute care and appropriate skilled nursing facility beds and staff. And I want to emphasize the importance of care coordination and telehealth in supporting survivors and their caregivers through this journey.
Great. My name is Matt Gannon. I work in the Bureau of Equitable Health Systems on the NYC REACH program, and I'm going to speak briefly today about resources for ambulatory care providers. Next slide. Thanks. So a little bit about me and about our program. So NYC REACH is a membership program operated by the Bureau of Equitable Health Systems and within the health department. We are a free membership organization. We partner with most folks in the New York City healthcare delivery system, from smaller private practices to FQHCs and clinics, hospitals. And our goal is to help provide technical assistance and capacity building to improve population health. So a lot of time that looks like supporting information of new technologies, EHR and such, so supporting with workflow consulting and disease-focused quality improvement projects. We provide resources and trainings to our membership most of the time, but with the public health emergency, we are expanding our resources and our offerings to include the New York City provider and healthcare delivery system at large. So I'm going to talk a little bit about what our current offerings are and what we make available to the New York City delivery system. So the first, and this follows nicely from what Dr. Claude was speaking about, how telehealth is a key component of post-discharge follow-up for COVID patients. It also has been for many the prevailing part of your day-to-day operations for the past couple of months. And at this point, everybody we hear from, or many that we hear from, are focusing on the shifting from the kind of telehealth that they stood up in March when they needed to get something together to maintain any continuity of care, to something that they can sustainably incorporate into their ongoing practice operations now and for the long term. So, we've seen that the uptake has been really great. We offer weekly telehealth crash course webinars that we make available to New York City all practices. And what we've learned is that folks have done an outstanding job getting started with that. And where everybody's head is at now is to make sure that what they've implemented is sustainable. What do our protocols look like? How can I integrate this into my strategy for infection control as I reopen or expand the hours of my practice? So NYC REACH offers trainings, technical assistance, and an email hotline and a website with resources to help you as you're thinking through this. I'll share some of those links a little bit later. So a few of the recommendations based on the best practices that we've seen among our folks working on this now is that you are incorporating protocols for telehealth into all of your visit workflows, especially if you're returning to in-person visits for the first time, or if you're starting off with that now. Think strategically about how you are scheduling telehealth visits when you'll also be doing in-person visits, making sure that your patient-facing messaging, whether you're doing email blasts or phone campaigns to patients whom you need to inform, is appropriate for your population, and making sure that your video platform that you're using is A, that you have a video platform, and B, that it is HIPAA compliant, because some of the restrictions or the loosened regulations around HIPAA compliance we anticipate may go away before this public health emergency in New York has concluded. So NYC REACH is happy to partner with you on this. We'll give information a little bit later about how to get in touch with us and what kind of support we can provide. So one thing that came up on last week's provider webinar was spoken about comprehensive risk stratification among your patient population, thinking through, based on conditions that you have, based on conditions that patients have, are there certain patients who are too high risk to really be leaving the house? Are there patients who I need to prioritize to reach out to first to engage in telehealth or an in-person visit? Are there folks for whom some delayed care may be especially concerning? So it's something that is very interesting to talk about, but as EHR data goes, sometimes very difficult to do. So we make available tools on our website to help simplify that process, and we welcome questions to our email hotline, or that you can join one of our weekly trainings to learn more about this and figure out how you can make this possible. You can identify, who are these patients who perhaps from the CDC list of conditions placing you at higher risk for a severe negative outcome from COVID. Who are these patients that I need to make sure that I have somebody from my office call and talk to first. So that is one of the, so telehealth and kind of looking forward and optimizing how you've implemented telehealth as part of your expansion strategy and your post-discharge management strategy. That is our big program right now. We've also partnered with some others to help meet some other gaps. One of our partners is the New York City Medical Reserve Corps. And if you are not familiar, this is a volunteer group of 13,000 licensed clinicians who volunteer their time to respond to public health emergencies. It's a national program. Locally, the New York City Health Department operates our New York City Medical Reserve Corps. But if you are finding that as you are planning to reopen, or as you're expanding your hours, that a big gap you have is you need more clinical hands, like from a physician or another provider, like a nurse practitioner or a physician assistant, or a nurse, an RN or an LPN, perhaps a social worker, and having some extra support for some time, for like a limited amount of time, would be helpful to you in doing that. We encourage you to request this kind of support through the New York City Medical Reserve Corps. We are hosting a webinar next Friday, 1 week from today at 11 a.m. That if this is interesting to you and sounds like it would meet a need that you have right now, I encourage you to sign up. Just to throw a couple of the ideas that I have been hearing and that we've been hearing folks consider. If you have some patients who are isolating, who are COVID positive, and you would like an extra pair of hands to help do some telehealth monitoring, if you're looking at doing every other day check-ins, but that's something that as a physician or a provider, you have a hard time making that and everything else happen, you can request a remote volunteer physician or provider to help with that. If you're standing up like pre-encounter triage of maybe COVID symptoms for your patients, you could request support from a volunteer nurse. Or if you're a pediatrician and you have patients for whom you're worried have fallen behind on vaccines due to the public health emergency, and you want to have a couple of days a week vaccine clinic for a few weeks, you can request nursing support for that. If your patients who are experiencing different social and community resource needs than perhaps they did before, you might request a social worker. So there's 13,000 of them. Over the past couple of months, 1,900 or so have been working in hospitals and nursing homes. And we would like to make the outpatient space aware of this as well. So if this sounds like it could meet a need, I encourage you to attend our webinar, get information on how to initiate something like this. And then the last related thing, so we also partner with the New York City Health Information Exchanges, and there are two, HealthX and Bronx Rio. They are centralized information hubs for patient information that all hospitals in New York City connect to, and a lot of private practices and almost all health centers. So they hold data in a central place that aggregates it from these different contributing sources, and they give notifications when something happens with a patient. For example, if you are a member of one of these health information exchanges, you will get an email letting you know that your patient has been discharged. They've also recently implemented COVID testing alerts. So if you are a member of one of these health information exchanges, one of these RIOs, and a patient has a COVID test result come into any of the other participating facilities, you'll get an email making you aware. So to help with those care coordination needs and getting data, especially for the following a care transition time. We're happy to connect you with those if that's of interest to you. That's good, we can go ahead. So if you are interested in learning more about telehealth through our program, talking through some questions, or you have any lingering questions as you're looking to scale up or change how you've implemented telehealth recently, I encourage you to reach out to us. If you are looking for support in using your data to do some meaningful risk stratification that will help you make decisions, we are happy to help with that too. If you're interested in the Medical Reserve Corps, please do get in touch. Our email address is right here. It's nycreach@health.nyc.gov. And we made public our resources at nycreach.org around all of these topics and some more. If you'd like to become a member, it's free and you'll get email updates on the policy changes and upcoming financial resources. One more thing to plug. I think we do encourage, for those who are, it's come up a couple of times today regarding social service and community resource needs. I do want to plug the New York City Health Department's COVID-19 resources by neighborhood, which includes information on some of the really heavy hitting social service and community resource needs in each neighborhood. For example, you have food pantries that are open, pharmacies that deliver to help meet some of the needs that are being seen right now in your specific neighborhood. Thanks.
All right, thank you, Matt, for sharing that important information and to all our presenters. It looks like we do still have some time for questions. As a reminder, you have all been placed on mute, but thank you for entering your questions in the Q&A box in the WebEx. And also a reminder that these slides and a recording of this webinar will be made available on our website, the provider page at the top of the screen there, by next Monday at the latest. So let's see, our first question is for Dr. Kolod and Dr. Ray, and it's about anticoagulation on discharge.
So I think, well, as Dr. Kolod gets to the microphone, she can speak about reinforce the information on the post-ICU discharge. I think there's also a lot of question about, and I think we talked about this when we talked about anticoagulation in these webinars a few weeks ago, but there are a lot of anecdotes about patients presenting with severe anticoagulation, even if they don't seem to be that sick, or having sequelae of thrombosis on discharge, even if they haven't been in the ICU. And I think although there aren't, there is the guidelines I said they are developing or emerging, but there's a paper we cited that says they're actually lacking. This is a huge review of guidelines in a lot of large facilities in the US and Europe. So I think one of the most important things is that for all patients, you want to draw a series of labs, coagulation labs, and then I'll post the link for the algorithm by the international, I forget exactly what it's called, the International Thrombosis Society. But you do want to follow those up. And I think for any patients with elevated D-dimers, elevated CRPs, for example, you want to think about it. The other point that I think many people have talked about with relation to anticoagulation is it's not a benign intervention. There are bleeding risks, and certainly patients who are walking around and who are outside of observation, there's a bleeding risk associated with it. And so certainly you want to, very often prophylactic anticoagulation is indicated for sick patients, but you really have to think of you have to be very, very careful about using therapeutic anticoagulation.
Thank you, Dr. Ray. And I'll just add a bit of detail about the guidelines that I shared that are shown on this slide. So for the gray area, the area in which prophylactic, intermediate, or therapeutic anticoagulation can be used empirically. Some of the background for this guideline, the cutoff of D-dimer greater than 1,500, that number is a different number is used in different hospital systems, but that number of 1,500 nanograms per milliliter comes from data from China showing that it had about an 85% sensitivity and 88% specificity for finding venous thromboembolism in patients with COVID-19. However, the idea here in anticoagulating these patients is that, as I mentioned, we're intending to anticoagulate microvascular thrombi, which we may not be able to recognize otherwise beyond the elevated D-dimer. And additionally, just to clarify these guidelines, so for those with reduced mobility, active malignancy, or elevated D-dimer greater than or equal to 2 times the upper limit of normal, no more than 45 days of anticoagulation would be recommended. So it can be shorter than 45 days, but those who have higher risk, we would go out to 45 days just as prophylaxis. And then for those who have documented objective evidence of venous thromboembolism, those are the ones who would go out to a minimum of 3 months, or it could be longer depending on their risk factors.
Thank you. Next question is for Matt. Does NYC Reach support telehealth for private primary care providers?
Yes, please reach out to us.
Great, easy answer, thank you. The next question is for Dr. Foote, with some questions about fecal transmission of COVID.
Hi. Fortunately, I love talking about poop as an infectious disease doctor. So there have been some recent studies, a couple that have, so going back, we've seen positive PCR for stool samples in COVID patients, and we've known that for a long time. But as we've talked about before, there's a big difference between PCR positivity, which just detects genetic material, versus viral culture, which shows us whether or not a virus, that there may still be viable virus. And so recently we've had a couple studies that have shown culturable viable virus in stool samples. And unfortunately, we still don't really know what the transmission implications are for that. The data, is still not really robust enough about that. However, one thing we do know is that we have seen a lot of the environmental contamination studies that show that there's a huge amount of contamination in bathrooms around toilets. So if you have a lot of time on your hands, you can go through the literature about microaerosolization when you flush your toilets. So that is, just something to be aware of, and also just really, really emphasizes the importance of environmental cleaning, especially in bathrooms, and ensuring that patients that are being cared for at home with family members have their own bathroom, just to limit, the risk of that type of transmission. But on a related but different topic around poop, we are also really interestingly seeing some really promising data about using looking at PCR studies of wastewater samples to look for the presence of COVID DNA or SARS-CoV-2 DNA to serve as something of an early warning system for increasing community transmission. And this is something that's being looked at for application, potentially in the US, but also several other countries in Europe are seriously looking at this as another surveillance mechanism. So just another interesting fun fact on the topic of fecal matter. Okay, and then we have another question. We talked about this last week, but I think it's good to address again, since there are still questions about really what does it mean when you have prolonged PCR positivity, and also, and especially if it's somebody that has completed their isolation period and have had resolved symptoms, or have had a negative PCR and then have a subsequent positive test. So as we just mentioned, there is a big difference between PCR positivity, which, really just detects DNA. So it could be from dead virus or non-viable virus. It's still just sort of being kind of shed from the body, versus viable virus, which is, we can culture it and show that it can be infectious in cell cultures. So what we do know is that there have been a couple studies now, one out of China and one, I think, really great, robust set of data that was released by the South Korea CDC, looking at a cohort of people who had been kind of identified as prolonged viral shedders, or people that ended up coming back as positive after negative tests. And there was actually a cohort of 800 contacts of these patients that were being followed, and over several months. And none of these contacts in these cases were shown to have been infected or demonstrated transmission to these contacts. So we are also, there's been some, in the same study, they also did viral cultures on some of these patients and showed that they could not culture the virus. So it is suggestive, but not definitive, to say that a lot of these cases, at least, are probably prolonged shedding of DNA, not necessarily viable virus. But I think, there's obviously still a lot of research to be done on this. And I think one other thing that people are looking at, and studies going on are looking at, unfortunately, it's hard to do this because you have to have an initial sample of kind of from the initial phase of the infection. But if you can get looking at initial samples versus these later samples of the virus that are 4 to 6 weeks out, and doing genomic sequencing where they can look at whether or not this looks like the same virus or a different, basically a new and unique infection. So studies are going on, so stay tuned. Maybe time for one more question.
Actually, one for Dr. Kolod. So Dr. Kolod, we have a question about paresthesia in the hands and feet for post-ICU patients.
Thank you for the question. Yes, paresthesias are one of the widely recognized complications in post-intensive care syndrome, and also considered one of the neurologic complications of COVID-19. So it can happen due to positioning in the intensive care unit, or it can be a neurologic effect of COVID-19, which is known to cause neurologic complications of the central nervous system, the peripheral nervous system, and then also the skeletal muscle. So this is an expected consequence, and this is a reason why it is advisable to include neurology in your post-COVID-19 follow-up.
And then I just wanted to mention the treatment of COVID-19, clinical ICU course of COVID-19 patients relative to other acute respiratory distress syndrome patients in the ICU. COVID-19 patients who are ventilated seem to stay ventilated for longer, and there's a greater incidence of ventilator dysynchrony, or fighting the vent, requiring sedation. Additionally, many providers, given the really tough to handle cytokine storm and inflammatory response in COVID, have been providing steroids along with paralytics at the same time, and that is that can really cause a lot of muscle weakness and myalgias and neuromuscular syndromes.
I think that's about time for our questions today. Thank you again to all our presenters, and thank you to all our attendees for joining us and sharing your time with us as always. We will be back next Friday at 2. In the meantime, you can find a recording of this webinar as well as slides, which also include references for Dr. Kolod's presentation at the end on our website at the top of the page there. And we hope that you have a good afternoon. Thank you.